specifically on the HIE part of data segmentation and of the being able to address this issue. We're going to start with a policy level view, then some experience across different settings, different countries of really applying different policies, then a technology approach, a large implementer from the Department of Defense, and then a view from the consumer advocate, civil liberties approach, and then hopefully have time for some questions and discussion. We'll start first with brief introductions, just quickly down the line.
Good morning. My name is Mark Rothstein. I'm the director of the Bioethics Institute at the University of Louisville School of Medicine.
Good morning. I'm Romulo Juarez. I'm a partner with Accenture in our health and public services sector, supporting our connected health practice.
Good morning. My name is David Staggs. I'm the CTO of Jericho Systems Corporation.
Good morning. My name is Richard Thoreson. I'm with the Substance Abuse and Mental Health Services Administration, Project Officer for HIT.
Morning. I'm Colonel Scott. I'm with the Office of the Assistant Secretary of Defense. I'm the Clinical and Informatics Program Director, Policy Program Director as of January.
And my name's Corinne Carey. I'm the Assistant Legislative Director at the New York Civil Liberties Union.
Very good. Okay, we'll start with Mark Rothstein.
Thank you. In my brief opening remarks, I want to see if I can put out the framework for trying to think about health information exchange and the options that are available from a policy standpoint to give patients more control, more options to decide what they want done with their information and how it would be exchanged. So the first of the breakpoints or decision points would be whether individuals have any choice about participating in a health information exchange. And it seems to me there are three models, and there are HIEs out there that embrace all three of them. The first model is you just don't ask, don't tell, you just use it. And that, I think, has become an increasingly untenable model for health information exchanges, but it's still being used. Second one would be to give patients the ability to opt out of health information exchange. And the third would be to have an opt-in process. And you can imagine all the pros and cons of the various options. We can talk about that. The next issue to consider is if patients are in, having elected to do so, or maybe not having elected to do so, whether they should have any control over the substance of the information that is exchanged. And that refers to patient controls. Some health information exchanges don't think that patients should have any controls. Others increasingly recognize that they ought to, but they're not sure how to do it. And from a policy standpoint, there have been two main proposals in the last couple of years to deal with this. One is the so-called PCAST report from the President's Council of Advisors on Science and Technology, which recommends a highly granular capacity to control information. And the other main option comes from the National Committee on Vital and Health Statistics, which is what can be described as a categorical model, where there are certain categories of sensitive information that individuals should have an opportunity to restrict from disclosure via the health information exchange mechanisms. The final question would be whether these models for information exchange in healthcare also apply to information exchange that go beyond healthcare on the basis of one of the provisions of the HIPAA privacy rule for public purpose disclosures such as public health, law enforcement, national security, and so forth, or pursuant to an authorization. And finally, I want to briefly say why I think this is important. Yesterday, there were some people who challenged some of the speakers, including me, on the question of, well, where is the evidence that actual harms have taken place from a disclosure of information, de-identified, identifiable, whatever. And I think that's not the right question to ask. I think the question to ask is what happens as a result of the lack of opportunity for people to have meaningful choice in this information. With interoperable, longitudinal, comprehensive health records, we have the potential for a breach of privacy that's far greater than anything we could imagine under a paper system. So we not only have the tangible problems of stigma, discrimination, and so forth, but there are the health problems. There's lots of evidence that people engage in defensive practices when they don't trust their healthcare providers or their healthcare system to protect their privacy. That would be very bad in terms of patient outcomes and continuity of care and tying the hands of providers. And the other problem is from a public health standpoint. I don't want to live in a country where people who have infectious diseases are afraid to seek treatment because they're afraid that information is going to follow them around the rest of their life. And I don't want to live in a country where people who have substance abuse or mental health problems forego timely treatment because they're concerned about the consequences. And we need to be thinking about this from a public health standpoint. So whether we have a whole litany of documented abuses is not the question. It's the issue is what's the effect on healthcare.
So I'd like to talk today about our experience in around the globe. Currently, Accenture has about 30 HIE implementations going on. And this is experience that we've brought over from Europe and APAC, for example, and they tend to be leading the way and a little bit farther ahead, actually maybe a lot of bit farther ahead than we are today. They have the simplicity of either a single body or just a few key federal states that need to make these decisions on patient privacy rules, and so it's actually easier to implement in those areas. When it comes to the technology, when we look at the reasons and the barriers of HIE and adoption, and when we talk about patient privacy, it turns out that from a physician's and a provider's point of view, patient privacy is not the #1 issue. It's the #2 issue. #1 issue is they're concerned about their data systems talking to one another. The second issue of almost equal importance is patient privacy. So we deal with that a lot. And in an implementation perspective, I can tell you that there's a lot of focus on the technology and getting the technology up and running. And the word of caution there is that our advice is you really look at the people, the policies, the procedures that you need to put in place, and the controls. Because it's ultimately the humans that are involved in these systems that are allowing patient privacy potential breaches and or harm to occur within the system. In addition, with the new HIE technologies that are coming out, there's been a drive toward a lot of physicians asking for the EMR to be their single point, their portal of access. And what we're seeing, the request is that the HIEs are fully integrated now with the EMRs. They're coming in, and so you don't have to go to a separate window, and they're going to be integrated in a button you click, and you don't escape your current EMR. And the challenge with that is, and there's some technologies out there that are allowing this, is that these EMRs and those HIEs will allow the ability for business rules to automatically pull patient data within their systems, whether the consent was there or not. So that's the danger. So we have to look at, again, we really need to focus on the policies and the procedures. The other example I would give you is, we do have challenges when we go through adoption, and we look at physician-clinician adoption. There's certain segments of our physician population that are not as readily equipped to utilize the EMR technologies. Now, they may be, in some circumstances, logging in and having a clinician, a nurse practitioner, or someone else within their staff working the system, which, when we look for security and privatization, we really want that doctor on that system. And so balancing the technology, the policy, and how it's implemented is really the challenge that we're facing in all these implementations. And as I said, not so much in Europe or Asia Pacific, but really here in the US, where we have multiple regions within multiple states that we have to deal with different governing bodies.
So I'm here to talk about technology, so I don't have to worry that much about all the politics and the policies that have to be in place. I will say that I agree with Mark that privacy is becoming more and more important. The recent European Parliament paper that came out in January of this year, and the Consumer Data Privacy and Network World that came out from the White House in February, both say that patients should have some meaningful consent. They both stress that patients should be involved in their health care. So what we do at Jericho is we make the authorization pieces that fit in to different systems, as Romulo was talking about. What I would add is that some of the issues when we're talking about data segmentation and patient-centered options is, where's the data? Is the data going to be held in a central database? Is the data going to be held federated? And we have been working this problem for several years, and the traction we've gotten has been focused on, well, what happens if providers keep their patient information and you have a federated system, meaning you make a request, and each time you make that request you get the most recent data, and that's called the edge of one organization. So if you could look at the edge of an organization, perhaps you could make those requests and responses have the attributes that are necessary to allow patients to give consent or for organizations to determine whether that access should be allowed. So we've been working for several years on this. Richard Thoreson and other members have been working in standards organizations, and we've developed these attributes back in 2008. Several vendors showed them. So we're working in concert, and we're trying to provide the standards that it will allow people at the edge of their organization to determine whether something should be released or not. We're doing it in a policy-based approach. So no matter what the policy is chosen, we'll be able to provide that. If you do opt-in, opt-out, we can do that. It's all just policy to us. So I think we're looking good as far as the exchange of information on the technical level. It's just an issue as to how we're going to push forward the benefits to our population without risking any harm to our patients. That's a very serious topic. The loss of patients has a profound effect on their families and on their future generations. So we want to give the most benefit as possible with the least amount of additional risk. I could say from my experience that the issue of opt-in, opt-out is very complicated. If you look at the Veterans Affairs, they have about 7 million beneficiaries, or they're treating about 7 million patients. How do you get that done if everyone using paper, right? So you have to look at the workflow, you have to look at the attributes, and if you have the right foundation, I think we can move forward.
That's good statements, David. My name is Richard Thoreson. I'm with the Substance Abuse and Mental Health Services Administration, and we've been concerned about granular consents for 35 years. And we've done it mostly with fax machines and manual processes. And recently, I think we've become aware, as I think the VA has become aware, that a lot of the new requirements about sharing records and segmenting at a fairly granular level really can't be done manually. It's too expensive, it's too risky, and people don't want to face it. And so unfortunately for us, people don't share our records. This is a substance abuse, especially substance abuse, but there's a lot of other situations where it's similar, very potentially stigmatized information. So we're working in a very similar vein to what David talked about with Jericho, is that we're with standards organizations, with the Office of National Coordinator, and something called the Data Segmentation for Privacy, DS4P. We're trying to figure out, and the process of modeling that has already been done by that work group very well. And so we're trying to we're proposing, and I think we will do it if we get all the things lined up, we will do a pilot test of that, those use cases, that implementation guide. SAMHSA, as I said, been very involved in this for years. We have a very strong policy interest in making sure that our records, especially records, sensitive records, can be widely shared, but with consent. So with that consent, Dr. Clark emphasized that earlier today, that consent is the key to everything in terms of sharing. So we would like consents to be ubiquitous. We would like access control service sitting in front of every provider organization, repository, every HIE, anybody that's holding sensitive information, and then in the process of specifying how this access control system service works, it's a very open process. So people can develop the kind of trust we think is essential so that you can trust the computer, probably more than you can trust the human. And that's the kind of approach we're taking, and we hope to be kind of a technology leapfrog. So when policymakers say, and we've heard from other folks here, well, you know, we really can't do that sort of thing. Well, the hope is that any legacy system out there can use this service. In the exchange process, in that exchange process, a C32 or CCD, the machine can understand what's in the record, the machine can understand the policy, and do the appropriate redaction and tagging, metadata tagging obligations automatically. Thank you.
Well, I mentioned I'd been in the Secretary of Defense Policy Office since January, and that was so I'd get a chance to explain how I got there a little bit. I'm a physician, been in the Army my whole career. I've been about 20 years in the Army, and I've been on the side of the consumer of all the information we're talking about sharing, and I've always felt like I could never get enough. I'm a pediatric cardiologist. Patients go downtown for the operation. I want that op report in front of me when I'm taking care of them. So I've come into the policy office recently and now learning from this conference and in talking with many of you the enormity of the problem in front of us. In the military healthcare system, if for those of you who don't know, I know Captain Wiener alluded to it a little bit, but we are a pretty big healthcare system. We have 9.7 million beneficiaries. 1.7 million of those are active duty soldiers. Another million are retirees, and the rest of those 9 million are those people's family members. So we have births in our hospitals. We have NICUs. We take care of elderly, retired people with benefits. And we have to share everything that we've ever done with our active duty soldiers to the Veterans Administration when they separate. So we have been sharing a great deal of information with the Veterans Administration directly in a relationship that really obligates us to send them everything we have. But we're now looking at how we're going to participate in NWHIN and HIEs in order to accomplish what the White House wants us to, which is called the Virtual Lifetime Electronic Record, which encompasses more than just the health record, but specifically for our issues, it's thinking about that health record. And we are looking at how to get through the NWHIN and through applying these technologies and policy, everything into that record that we can get. And it's a pretty big problem. We have a huge legacy system. I mentioned we've had electronic records since I've been in. So we had rudimentary order entry and for labs and things. But beginning in 2004, we've had a global record with a single central data repository called ALTA. And we've prided ourselves on the fact that within our system, we have a mobile population. A patient can go anywhere in the world, and that clinician's going to have access to the whole record. So how do we allow that sharing into the Nationwide Health Information Exchange when we're sending our patients downtown is the problem that's in front of us. And we have only taken initial steps at that. The first panel this morning, you mentioned how the military is doing things slowly and deliberately. And while that seems very frustrating to a lot of our providers, I'm glad we are at this point. We've got in the pilots that exist so far for this exchange with the NWHIN, there's no opt-out, but we're only sharing information on those active duty members. We are now trying to decide how to include all that beneficiary data into a system and looking at the choices in front of us, opt-in, opt-out possibilities, but we have not yet formulated that policy. And do I have another minute? Just obviously, I mentioned I've got the side of wanting all the information we want, but of course are very sensitive to the types of harm that you've been talking about, especially those that would lead to a barrier to care. The stigmatization of mental health disease has been a huge issue for us in the military, with a suicide rate that's going up, and we've been doing what we can and recognizing that stigma is a barrier to care, especially if people are afraid the information is going to be shared. But the risk, of course, has to be put into perspective. And I think as we figure out how to apply the consents, giving the patient the perspective on that risk is going to be one of the really tricky things to do. Risk of not sharing versus risk of sharing, and we'll be confronting that as well.
So I'd like to talk a little bit about how all of these things boil down and get implemented at the state level. I'm from New York State, and in our state, we began implementing electronic health information exchange around 2007. The state issued a consumer consent white paper, and we were called on as the Civil Liberties Union to assist a local Planned Parenthood affiliate in trying to parse through what this new regime would mean for the confidentiality of reproductive health care records. And when I first started to look at the issue, having no background in technology, I quickly realized that this kind of a sea change in the way that records are kept would have huge implications for medical privacy writ large, not just about reproductive health care. And so that began the NYCLU's journey into the policy development process in the state. New York State started implementing health information exchange before its policies and procedures were fully developed. I know a lot of states have grappled for years in trying to tease out these policy issues prior to implementing exchange. It was kind of done the other way around, and you can see both benefits and detriments to doing that. But some of the issues that we grapple with, and I currently sit on the state's policy committee around privacy issues. We deal with issues of consumer consent, with data segmentation and patient control over who sees what, and with role-based access standards, who gets to see what kinds of information, with what level of consent, and why. And I think New York, we talk about an opt-in or an opt-out model. New York has kind of a hybrid model. Patient information is, and I'm going to use shorthand here, is uploaded to a system that makes that information accessible without patient consent or notification. That's a huge issue for us at the New York Civil Liberties Union. The state maintains that, well, of course they require consent. They require consent to access the data. But I think we all know that there are, once information is accessible, not only those who get consent from the patient can access it. We know that for maintenance and operations purposes at the local regional health information organization level, those folks can gain access without patient consent. Our state has a break the glass policy where if a patient is incapacitated and unable to give consent, the physician can, or the clinician can access those records. We're currently in negotiations about whether government entities, departments of health, can gain access to identifiable data without patient consent. And then, of course, as we've heard throughout this conference, there are the bad actors who can either hack into systems or who can gain access through lost, stolen laptops, key fobs. We have concerns over, the consumers have concerns about breaches in security, about violations of law and policy, but I think the policies themselves are very important. Consumers are concerned about policy development. The second issue that I think the state is grappling with, the most important issue, although there are many, is about the patient's ability to control who sees what. And we've heard a lot about data segmentation here. And the state has been resistant to the idea that one way to solve some of the vexing problems of, information about minors that has special confidentiality concerns, information about substance abuse treatment and mental health treatment. The answer really is about data segmentation, and the state has long maintained that the vendors don't have the capability to allow for that kind of patient control. I always say, though, that I refer people to the Field of Dreams and Kevin Costner, and I say, if we require it, they will build it, just like, if we build it, they will come. And so I think it's important that state policies be prospective in terms of what kinds of privacy levels we want to impose on systems. And so if we require that the systems have the capability to segment data in a way that can allow greater patient control, then the vendors will come along and begin to develop that capability. And we already know that there are many vendors who can do that. It just may be that the states chose vendors initially that constructed systems without that capability, and that might become much harder to sort of march back and make sure that that capability is there. So I'll stop there.
Okay, well, panel, you did a great job of moving through that. So we have about a half an hour for questions. And what I want to just remind people, a number of people have come in since we started. With this topic, which is very broad, we've asked the panelists so that we could have a meaningful discussion and not just spread out across the whole spectrum, to look at the patient controls, patient-centered options, and data segmentation after the data is left an entity, an enterprise, a record, so that there are issues about what happens about who can see things within an enterprise that we're not going to be talking about. We also sidestep the issue of what happens if the particular EHR, EMR doesn't have the capability of segmenting, because with 600 or so products, if you try and do it there, we'll never get there because there are many that can't do it. So the idea is, can the HIE actually provide a capability for patients to control what data is shared or how it's shared without having to back that into all of the legacy EMR, EHR systems themselves. So if you'll keep your questions in that realm, understanding that we know that there's a lot more there that we could fill up a whole conference about, that'll be helpful. Let me ask one question and then open it up to the audience. We have talked about both the limitations of the current system, maybe where, unlike some concerns that we had where technology dictates policy. In this case, it's the absence of technology that may be dictating some policy, and that means that there is going to be limitations for people who choose to opt in or choose not to opt out for their data to go, which, as we've heard over the conference, they can never get back in. And there may be, in fact, 50%, 60%, 80% of, or more, of individuals who don't mind that data flowing, at least to their providers. In fact, I think all the opt-ins have gotten over 90%, flowing it to another provider. The issue isn't getting it to another provider who's caring for me, it's getting it outside of those who are caring for me. So that we have a, here's where we are now, here's where we want to go. Is there anything that we may want to either do for policy or for education for individuals to help them get from here to there, and helping the system to enable that transition, so that we aren't just, as some people have, it's just wide open, or a all-in, all-out choice right now, and acting as if that's all it's going to be. So let me ask the panelists, how might we, given your experience in your areas of expertise, how can we handle the need to transition between the now and the future?
So I would say two things. I think the issue of consumer education and the capability of consumers to understand these highly technical issues came up a lot through this conference, but I think it's really important that consumers know what's happening, what the system's capabilities are. The worst case scenario for me would be a breach in New York, where consumers would contact me, contact the ACLU, without having ever known that their information had been made accessible. And I don't understand why the state would want to see that. So that's what I've been emphasizing, is that it's really important for consumers to know what's capable now and what's happening. The second thing I'll say, and it's just re-emphasizing what I said earlier, is that I think we need to, at the state level, adopt prospective policies. We need to adopt policies that require at some date certain, or at some date near in the future, that our systems have the capability to protect privacy the way that our laws protecting paper information intended privacy to be protected. And so I would encourage anyone working at the state level to push state policy-making bodies to adopt prospective policies, knowing that the technology may not be available right now, but it will be in the future.
So, and I would dovetail on that comment, on those comments. Specifically, if you've read the book by Ray Kurzweil, Singularity is Near. So we are at that point where technology is changing so rapidly we can't see it coming. And I know in our innovation labs we try to say 3 years out, and I tell you what, that's a struggle. Staying 6 months out is really where we're at. So I think in talking and focusing on policies, procedures, and training, I think the technology capability will be there to be secure, and it will be there quite likely in the time frame that a lot of these HIEs are rolling out, because if you look at the timelines of a lot of these HIEs, especially at the state level, they've been pushed, and they're slow in coming because a lot of the focus is now on the large IDN HIE development. So the technologies are there, the innovation is there. We really need to focus on the policies and procedures.
Yeah, I'd like to support that thought, and that is that even without any change in policy, the technology is going to be racing ahead. And we've been playing catch-up for 10 years at least in terms of developing policies to deal with the technology, and it would be nice if we could sort of be forward-thinking and try to develop policies that are going to be able to dovetail with the new technologies that are just sort of on the drawing board. The other point I want to make is regarding consumer education. Life is going to get a lot more complicated for everybody, and that includes users of healthcare. We have a major problem now with health literacy and health numeracy, and it's only going to get worse. And for many people, they won't see the breakpoints that I mentioned earlier. That is, the first breakpoint is in or out, and then the second one would be segmentation. For many people, if you can't keep a certain element of their health records confidential, they want out. Right? So there's something in their history. Maybe they had a substance use problem, a mental health problem 20 years ago, some reproductive health issue. If we can't protect it, they're going to get out of the system of health information exchange to the extent that they can, and unfortunately for some people, they may avoid the healthcare system altogether.
And Mark, if you just earlier you had talked about I think one stream of consciousness of what happens if they opt out, what's it mean, but what's it mean to me if somebody else opts out, which I think is an important aspect.
So the question is, what happens to you as a provider?
No, what you had talked about the public health implications.
Sure. I want to sort of amplify on my concern about public health consequences of this. If people are afraid to seek care, it hurts all of us potentially. So an example that I used earlier was I don't want to be driven to the airport this afternoon by a taxi driver who doesn't have his or her TB treated because they're afraid they'll never be able to get another job or health insurance, or this will follow them the rest of their life. Or maybe I don't want to be walking down the street when someone is there who has a mental health or substance abuse problem or some other problem that should have been dealt with, but they can't do that because this longitudinal record is going to follow them for the rest of their life. It's just crazy that we would even contemplate any sort of system where we want to discourage people who are in need of care, who would benefit from care, and who, if they don't get care, is a threat to all of us.
And I'd like to comment on the flip side of that, the physician's perspective of seeing a patient and making decisions with the assumption that you're looking at a complete record. If a patient has opted out, is something going to alert me that I might be looking at only a partial record, or that some things might not be there? And do I have a conversation with the patient that says, well, I've done this complex risk-benefit analysis based on everything I know, but of course if there are things I don't know about you, it would change that. Now's your last chance to tell me. Okay, here's my recommendation. Thinking how those kinds of conversations would take place.
Well,
although, just to push back a little bit on that, John, we all know that with the non-interoperability that we have now, and with the right that everybody has to not share that as physicians we understand that we don't have we may not have a complete picture.
But if my assumption when I'm looking at I look at the electronic record before I go in to see the patient, and I say, I've looked at what we have in our record system. I often show them, here's what I know. If though I don't have that conversation very carefully, and I believe I'm looking at a complete record, I might make errors.
That's right.
Well, I think the key to what you just said is if I don't have that conversation and I assume that I can look at the complete record, that's the key. We should never be supplanting conversations with patients by looking just at the record. I think that it's a myth that we're ever going to have a record that will be complete and that it could supplant a conversation with a patient. So I think with most of the physicians and clinicians that I talk to, they all recognize that frank conversations with their patients, as they do now, should always be the norm.
And if I might say, what the technologists are doing is trying to support that with new workflows. So you look at the use cases, you do a systematic system engineering analysis of it, you come up with a workflow, and you incorporate that. The President's Council of Advisors on Science Technology released a report, and it talked about data segmentation, and it talked about the possible future of healthcare. And actually, Jericho demonstrated that at HIMSS 11. And what we did is we actually indicated that there was some data latent, so by using X's. Because we had the ability to block sharing of that information based on the patient consent, and that gave the doctor the opportunity to start that conversation. So it's possible to do, although it's difficult. The idea that Mark brought up, that we're lagging in the ability to use technology, you look at technologists' books like Fred Trotter's book, Meaningful Use. He says that we're 15 years behind everyone else when it comes to the implementation in healthcare of modern technology. And I agree that this whole issue centers around giving patients individual control, allowing them to have transparency, and then having accountability. So there's got to be a conversation between how this information is moved out of the edge to the next organization, and whether the patient can say, move this but not that. And I think I demonstrated that in when we accepted our award. It showed that patients that we do have technology to allow patients to choose what they can do. So I agree, it's education and workflow.
Okay, so at this point I want to open up to audience questions, and you've been very patient, thank you very much. If you'll say your name and the organization you're with before you ask the question, I'd appreciate it.
I'm Suchi Pahi. I'm with the Center for Democracy and Technology, but these are not their opinions or their question. So I was actually wondering, with the idea of uniquely individual identifiable health information that can be generated by health information exchanges, how would you deal with a patient's accessibility to that type of record? And if you've looked at the RFI, that's actually one of the questions, and they're like, should there be an opt-out from their information being collected by a health information exchange as a longitudinal record? How should they access it? Should they go through providers? Is there a technological solution that can have interaction between an NVE and a regular EHR that a provider or a non-provider is using to exchange data?
When you say RFI, is that the NPRM, the Notice of Proposed Rulemaking that came out of ONC just recently?
Yes. The one
yeah,
that
I
just
think
came out
everyone
recently.
should take a look at that.
Yes. Yes. But if you guys have any thoughts on that, I was just curious because I haven't come across any brilliant thoughts myself. So I'd appreciate any.
Well, I think given the risks of security breaches, of unauthorized access, I think patients should always be given the option to opt out. And I may be in the minority on that, but I think that patients have the right to know that whatever medical information they share with a provider can be kept confidential. And I mean confidential between the doctor and the patient.
I think as a policy goal, we want to develop a system where patients don't feel that they need to exercise the option to opt out or not opt in, as the case may be. I want to always have this option available to them, but I don't want patients to feel that it's their only choice to have any sort of control. And if you have the ability to segment information and put other controls on information, I think fewer people will elect the sort of the draconian opt-out, don't participate at all. And if we're foolish and don't give patients any option except opt-in or opt-out, they're going to opt out. And then that's going to defeat a lot of the value that we are trying to build into the system. So it's part of the same picture, in my view.
Yeah, we're confronting that potential awful situation of patients feeling like they weren't given a choice, and because they weren't given a choice, then they're all going to want to opt out. So we're trying to figure out if we can wait for the technology to allow us to have a little better segmentation before we implement Veeler for our dependents, or do we announce that at first you're not going to have an opt-out, but later you will? Right. It's a tough decision that's in front of us.
I think this points out this issue of the technology that's there now versus what we're going to have, and I think you hear a fairly consistent message that the people here feel that the technology is maturing and it will be there. I think we also heard yesterday about the pushback when a country pushes too fast, and where by having been forced in that situation, it actually may cause a pushback if there is no option. So that it may be that, for example, one scenario would be that the HIEs flow, but that people wait until they're comfortable, just like on the internet. People had a choice when they wanted to use a credit card, and so there wasn't a pushback to say you can't use a credit card on the internet. People chose to do it as they were comfortable. Mm-hmm. And so but if society, if something happens where there's a breach and suddenly there's a reaction back, it can take many more years for the society to get back where it would have been. So there's a balance here. But I think that's an excellent question.
Hi, my name is LaRon Payne. I'm with the local District of Columbia Medicaid Agency and working with a group to develop a district-wide HIE. Romulo had mentioned the issue of interoperability and seamlessness in terms of the development of HIEs because, as Dr. Scott mentioned, clinicians want to have as much information as possible in order to make the best informed decision. I was glad to hear David mention that there is consent technology that has been developed to allow that type of data segmentation and to allow consent rules in there. My question is, is that consent methodology that's been developed scalable to work across jurisdictions that have different privacy rules? A consent an opt-in state versus right next to an opt-out state with very porous borders. Can your technology scale to include the consent rules for different types of states with different types of consent policies?
Well, can I address that? So this is just the beginning of this whole process. So there's going to be advances. But well, there's a number of things I'd like to say. But for example, in the jurisdictional issue, if you're looking at the approach that was taken by the Connect, which is federal architecture, joined together to provide this on-ramp for the NHIN that is used to share information, they actually encourage the use of a policy-driven decision. So that could be based on the organization's decisions. Doctors can access this, nurses can't. But you could also add, in addition, jurisdictional requirements. So if you were in Michigan and you were sending something to Wisconsin, the privacy laws might be different. So all we need is a safe harbor where governments would create what's called executable policies and executable policies and append that after the organizational. So I think that there is a lot of hope for scaling. A HIMA might look into this. They might come up with some model for enforcing privacy laws that we could add into the policy soup, and it would just work. And then, of course, in addition, we can add in the patient's policy. So taken across, once the privacy officer of that organization allows it. Taken across, we'll provide for the organizational rules, we'll provide for the legal rules and the patient's consent. So all of that looks very good, and I know that what we demonstrated yesterday, we specifically made it compatible with HL7, which is the format that's used for documents exchanged across the NHIN. So I think that there's a lot of hope for having scalability at that point. But we don't know. We don't know what's going to happen to the technology. We might be doing something in REST in a few years. But I think that if we stick to these principles, we'll be okay.
No, I just to add on to that, so we're involved in, I mentioned 30 HIEs around the globe. And we have some HIEs here in the States, and I've been involved in some that were multi-state. We've run into that issue before. It is a solvable issue. It can be managed. The problem we have today is that it's a very expensive solution. The vendors that have some of the capabilities to do it are almost cost prohibitive to implement today. So we, as a good partner, I should talk to you. We, as a good partner to our clients, are looking for alternatives today in our own innovations, but also looking at our partners to try to figure out how we can do this in a cost-effective manner versus, and I won't mention any names, but the larger vendors that are out there who charge a premium for this today.
Steve Weitzman, MedData Foundation, student of NYU and Dean Redlick, Norm Dorson. So I got a problem for lawyers. I look at the UK.
And you're a lawyer, so
I'm a lawyer, but a big science background, and NYU Medical School in biochemistry, so I'm a half-breed. But getting back to the issue, I look at the UK and the Great Britain Primary Care Database and how that's managed and regulated, and I'm puzzled about the fear-mongering, if I may call it. To me, as a civil liberties person, when I hear people say voter fraud, and there are 5 cases in the whole country, and we have to have all these laws now that are going to prohibit people from going to vote, I'm puzzling to the same people this whole issue of privacy. I go back to the HIV episode back in '84, '85. To me, the most important thing was implementing civil liberty laws that would have prohibited discrimination and injury for a breach of confidentiality. And I don't know why we're not emphasizing that protection for our people in order to build the trust first and not have to build the trust because, well, maybe people will do the right thing or do the wrong thing. I think we need to establish what's wrong And if it's discrimination, and if it's consequences from a breach of privacy, let's get that part of the public policy in place, and then we can worry about, yeah, it got breached, but what was the harm? If there was harm, you got to get taken care of. If there was no harm, then we're setting up a whole system and we're inhibiting ourselves for doing necessary research. And I'm not talking about the patient and the doc. You need that. Yeah. You have an obligation to give your patient the best treatment possible at that moment. Our concern on the privacy issue is people outside of that immediate doctor-patient relationship. And we're not segmenting the issue by those compartments. Those are my issues.
Well, did you go ahead?
No, go ahead, sir.
Okay.
We'll have time for one more question after we get brief.
All right. The brief answer
depending on how
is
quickly people are.
the brief answer is that it's incredibly complicated to deal with the non-healthcare uses of information, and what you might consider to be discrimination, the life insurance industry would consider to be sound medical underwriting. What you might consider, or I might consider to be discrimination, an employer might regard as essential to their business mission. And so it's not easy to say that let's just take care of the, quote, misuses of the information. I wish it were the case. And the fact is that our health privacy laws in the United States are awful. We've been debating since the 1970s enacting comprehensive privacy legislation, and it's never been enacted. All that we have, or the closest thing that we have, is this poor excuse called HIPAA.
Let the other lawyer answer, and then...
I'll be very brief. Well, it gives me the opportunity to plug our report. The New York Civil Liberties Union put together 10 strategies for regulating electronic health records, and we've been actually pushing at the state level to re-examine the privacy laws that we have on the books, which are more protective of patient privacy than HIPAA could ever be. But those laws were developed with a paper system in mind. And so we need to go back. The last time our privacy laws were revisited was around the HIV epidemic. And those laws were strengthened, but they were strengthened in the context of what is the backbone of our privacy law, which is about patient consent to release confidential medical information. It just so happened that HIV was the last time we had occasion to think about that. This is another opportunity to think about that. And I think that policymakers and lawmakers at the state level need to really think about those issues. And so one of the recommendations here is to define what misuse is, and then develop sanctions and punishments for misuse.
Okay, David, quick.
When you want to develop your technology view of this, I would encourage you to consider about the centralized versus federated model. The federated model has the NHIN, which we've been discussing, and the purpose of use is one of the attributes developed by ISO. So the purpose of use has a particular concept, and if you look at benefit, that means that the message coming in requesting information is from the Social Security Administration, and they would like to determine the benefit of a patient. And you can get 42% decrease in the amount of time it takes for them to make their decision if you use the NHIN. So possibly saving lives, because some people can't get treatment until that happens. So look at purpose of use if you're interested in the NHIN, and you'll see what segmentation is possible there.
We'll go to a former colleague of Mark's on the NCVHS.
Okay, Kathleen Frawley, President-elect of HEMA. Great discussion. The other thing that I think we need to add to the equation is identity management. And this hit home a couple of weeks ago when I was in New York City, and the Bronx Rio was presenting some findings. And they had 783 records linked to one name.
Oh.
Okay, one name. And again, you know, that's a discussion that we also need to the table. I mean, consent's important, obviously segmentation of data, but then the challenges of how do you know that it certainly is not that patient had 783 encounters. It's a very common surname in the Southeast Bronx, so the expectation is there are multiple people with that name, and because of poor registration practices, at the front end in doctors' offices and hospitals, they're now struggling with how do you prevent that from getting into the pipeline and decisions being made. And again, the other point I just want to bring out through this whole discussion, we keep talking about the EHRs, and most of our patients have never seen their medical record, whether it's in paper or electronic. And having worked at a federal hospital where patients carried their records back in the day, we still need to bring the patient to the center of this conversation. We seem to be talking a lot around that. So I just make that comment and share HIEMA's commitment, which has been going on now since 1928 on this issue. We've got to keep the patient in the center of this conversation, and we seem to be going off in many different paths. Thanks.
I'm going to
very
quickly. Quick question or comment, and
very quickly. David Smith, Mobile Health for Youth and Families Institute. 45 years in IT, seen a lot of buzzwords come and go. 20 years developing EHRs, promoting EHRs in behavioral health. Thrilled with how much progress we've made. Horrified when I first read the high tech. We're not ready for this. We have some wonderful things that are developing very quickly. We've just talked about how it's going to get better really quickly. We have a lot of data about each of us in a bottle. It's a genie. We take it out of the bottle. It's released. Our understanding of threats is changing dramatically. The new smart people talk in security is we have to assume that the bad guys are inside our systems. Now, how are we going to secure ourselves and protect ourselves in a world of Stuxnet and all of these other things? We're not ready to put everyone's health information online in 4 or 5 years. We're not ready to, we don't know enough to know how to support the physician. We don't know it yet. It's insane to be rolling these things out as quickly as we are.
Again,
we need to do it. It has to be done. There are phenomenally important conversations about who has the intellectual property right over my history. That has not begun, let alone resolved.
Okay,
and bullying people by saying we're the government, it's good for you, we're going to do it. To heck with what you think is a bad idea. Public, or my opinion only, but I think it's
thank you. We're actually at the end, but I want to give panelists a chance for at least a few words, and then we'll end. Anyone want to respond?
The flip side again to your comments are the enormous benefit that can be accrued by aggregating data in health record systems, and the questions that we can answer are potentially life-saving. Are life-saving. We know they are, and the harms are real as well, particularly in my view in terms of a barrier to care. But we know the lives we can save. Patients who have a condition that we don't know the answer to don't want to wait, and that's the flip side. And we have to balance these concerns. We have to balance the risks and benefits in a rational way.
Richard gets the last comment.
Okay, one sentence. Get patient consent. Control your risks.
A wise woman once said, the patient wants to be asked. Yeah.
With that, thank you very much to the panelists. Appreciate all you've done and the participation by the audience. Thank you so much.